GI malabsorption syndromes. All right, so for malabsorption syndromes, we have celiac disease, lactose intolerance, pancreatic insufficiency, tropical sprue, and Whipple disease, all right, or Whipple disease. So starting off with the highest yield one, celiac disease. You want to know celiac. Now, before we kind of get into everything, I think I should just do some overview. So malabsorption syndromes can cause diarrhea. They can cause fat in the stool, which is staturia, leading to weight loss, weakness. They can have vitamin and mineral deficiencies overall. And the screening for it is for fecal fat with the Sudan stain. So if they say Sudan stain's positive, they're talking about fecal fat. If they say guac test is positive, or guac or whatever it is, I think it's guac, I just call it guac, that's for blood being positive. But Sudan stain is for fecal fat, and that's gonna be helpful for malabsorption syndromes. Okay, so let's get into it. Celiac disease. For celiac disease, this is problems with gluten. Okay, so you have some gluten sensitivity, all right? Now, it's an autoimmune destruction or autoimmune mediated intolerance of gliadin, all right? And that's just like a gluten protein that's going to be in wheat and barley and rye, okay? You know these people, like you know that these people cannot eat gluten, what they can and can't eat. It's usually due to an autoimmune mediated intolerance of gliadin, all right? And what they want you to know also is that it's associated with HLA-DQ2 and HLA-DQ8, all right? 2 and 8, DQ, 2 and 8. Very important for you to know that. The way that I remembered it was that celiac disease, patients that have celiac can't eat the DQ cone, okay? And that's DQ 2 and 8. Now, it primarily affects the distal duodenum, all right? The distal duodenum is the main place affected in celiac disease. That is another high yield aspect that you must know, all right? And since it affects the distal duodenum, that is the location in which we have a lot of absorption, okay? And so we're going to see malabsorption symptoms and staturia because we cannot absorb at the distal duodenum, all right? Very important. Now, because iron is absorbed at the duodenum, right? We discussed that earlier. Celiac patients can present with iron deficiency anemia. So do not get confused. If a patient comes in with celiac disease and they show you that they have iron deficiency anemia, thinking back to hemonc, they have a microcytic anemia, be like, whoa, that makes logical sense because it usually affects the distal duodenum and iron is absorbed at the duodenum. So you can have iron deficiency anemia presenting as microcytic anemia, okay? So that's another key aspect that you need to take away. Next, it's outside associations. So when I say outside associations, I'm talking about everything associated outside of the GI tract. You're going to see dermatitis herpetiformis. Dermatitis herpetiformis is essentially like a herpetic-like rash that forms on people's hands and extremities with patients that have celiac disease. Okay, so it's just like a rash-like dermatitis that looks like herpetic in nature, all right? Another thing that you're going to see is that there's an increased risk of malignancy, specifically T-cell lymphoma. So patients with celiac disease have an increased risk for T-cell lymphoma. Keep that in the back of your mind, okay? Now, testing. They do this thing known as D-xylose testing. And D-xylose testing is going to be very helpful for our malabsorptive syndromes. D-xylose is essentially, all that it is just like, think of it as just like a normal monosaccharide that does not need anything in order for it to be absorbed. So it's just something in your body that just freely will be absorbed, okay? And the reason we give D-xylose to these patients with malabsorptive diseases is to see if there's an actual anatomical wall defect, problem with the actual wall, or if there's problem with like the enzymes that kind of help with digestion, right? So if there's an abnormal wall defect, an actual anatomic defect, then you're gonna have D-xylose test be abnormal. You're not going to be able to absorb all of D-xylose, okay? But if it's like a pancreatic insufficiency where it's the enzymes that are not being produced and that's what's causing malabsorption, you're going to have a normal D-xylose test because the D-xylose does not need any pancreatic enzymes in order to be absorbed. It will just be absorbed readily if the anatomic structures of the GI tract are normal. Does that make sense? So anytime you have an abnormal D-xylose test, that means that there's abnormal wall abnormalities. There's some type of anatomic abnormality going on or pathology. If you have a normal D-xylose test, that means you have a normal anatomy, okay? It might be just due to some type of abnormal enzyme production from the pancreas, okay? And we'll discuss about that later. So for celiac disease, since you know that it's an autoimmune response, autoimmune intolerance to gliadin, and it kind of essentially affects the distal duodenum and destroys the distal duodenum, what do you think the D-xylose test is going to be? It's going to be abnormal, okay? It's going to be abnormal. The reason behind it is because, once again, we have positive IgA anti-tissue transglutamase, okay? So IgA anti-tissue transglutaminase, that leads to the destruction of the distal duodenum, all right? And on histology, what you're going to see is villus atrophy, crypt hyperplasia, and intraepithelial lymphocytosis. Okay? I cannot tell you how high yield this is. If you see villus atrophy, crypt hyperplasia, and intraepithelial lymphocytosis, they are giving you the celiac diagnosis. They are telling it to your face right away. I will be so mad if you are a student listening to this right now, if you miss a celiac question and it tells you that there's villus atrophy, crypt hyperplasia, and intraepithelial lymphocytosis, I will be so angry. Do not miss these questions. They're easy. They're telling it to you, to your face, all right? So, very key, all right? So let me run through this one more time. Celiac disease, all right? You have a gluten sensitivity. So it's an autoimmune mediated intolerance of gliadin, specifically an IgA, anti-tissue transglutamase, okay? It mainly affects the distal duodenum. How does it affect the distal duodenum? It affects it by causing villus atrophy, crypt hyperplasia, and intraepithelial lymphocytosis on histology. Because it affects the duodenum, you're going to see malabsorption and statorrhea. Okay, malabsorption and statorrhea. And specifically, that statorrhea can cause, once again, vitamins A, D, E, and K, the fat-soluble vitamin deficiency. So don't get rattled if they throw that at you as well for celiac disease. But it can also cause iron deficiency anemia because the distal duodenum is affected, and that's where iron is absorbed. It's associated with HLA, DQ, okay? And it also has association with dermatitis herpetiformis and increased risk of malignancy, specifically T-cell lymphoma, all right? You're going to have a positive Sudan stain, which shows that it's fecal fat. That means that you have statorrhea, all right? The treatment, gluten-free diet, all right? This is celiac disease. Very straightforward, okay? Please do not miss the histology. It's so key. Next is lactose intolerance. Lactose intolerance is going to be essentially lactase deficiency. Okay, so you have no ability to break down lactose because you don't have lactase, or you have a deficient amount of lactase. What you're going to see is normal appearing villi. Okay, nothing's wrong with the villi, and so with the normal appearing villi, you're going to have osmotic diarrhea. Okay, so normal villi, osmotic diarrhea with decreased pH. You have to know that. So lactose intolerance causes osmotic diarrhea with a decreased pH and acidic diarrhea. Okay, now patients can present randomly after a viral infection with lactase deficiency, like lactose intolerance type symptoms. That's just an acute episode. It's just because a viral enteritis can lead to injury of the villi, and then it can cause lactase deficiency, but then it will be regenerated, and then those symptoms will go away. Okay, so if you ever see that, don't get confused. That could just be following viral enteritis. Okay, now one of their favorite questions is how do you treat it, or how do you diagnose it? Is with the lactose hydrogen breath test. Okay, positive for the lactose hydrogen breath test. All right, so lactose intolerance, normal villi, osmotic diarrhea with a decrease in pH and acidic diarrhea. And it could be following any type of, viral enteritis, which could lead to the damage of the tips of the villi, but it will come back normally. And then lactose hydrogen breath test is how you kind of diagnose it, okay? Next is pancreatic insufficiency. So the pancreas can let's say that you're not able to produce the enzymes from the pancreas, and it could be due to like chronic pancreatitis, cystic fibrosis, obstructive cancers. Anything that causes pancreatic pathology can lead to pancreatic insufficiency. Now, we know pancreatic insufficiency is very important, right? Because without all those enzymes, you're going to have severe malabsorption, because those enzymes from the pancreas help absorb pretty much a lot of things that we take in. So you're going to see malabsorption of fat and fat-soluble vitamins, A, D, E, and K. There's also one other vitamin that's not fat-soluble that you'll see a deficiency in with pancreatic insufficiency. Can you remember what we discussed? Yes, it's B12, vitamin B12, because the pancreatic enzymes are not able to cleave our protein from B12 in order for B12 to bind intrinsic factor. So without that cleaving, you can't bind intrinsic factor and you can't absorb B12. So you can also see a B12 deficiency along with the ADEK deficiency. Now, what do you think the D-xylose is going to be? The D-xylose test is normal because, once again, D-xylose does not need any additional enzymes in order to be absorbed. So it just checks the villi function, the functioning of the villi, all right? And you have completely normal functioning villi in patients that have pancreatic insufficiency. So D-xylose test will be normal. The next two are tropical spur as well as our Whipple's disease. So first, tropical spur is just it's going to be very, very similar to celiac, okay? And celiac is known as celiac spur. That's just another name for it. But tropical spur, very similar to celiac disease, but it affects the whole entire small bowel compared to celiac disease, which only affects mainly the duodenum. Okay, so tropical spur affects the entire small bowel. But it responds to antibiotics. Unlike celiac disease, where you have to completely take out gluten from your diet, tropical spur responds to antibiotics, okay? And what you have to think and look out for is a patient that had recent travel to the tropics, all right? That's all you really need to know about tropical spur, all right? Next is going to be Whipple disease. Whipple disease is an infection with T. whipple, okay, which is just intracellular gram-positive bacteria. It's just a bacteria. Now, what they want you to know about Whipple disease is that it's past positive, and it will present with foamy macrophages in the intestinal lamina propria. So you're going to have past positive foamy macrophages. Make sure you know what that looks like, and make sure you know past positive foamy macrophages, because it's very high yield for Whipple disease. Whipple disease itself is not that high yield, but you have to know it. And the way that the patient is going to present is they're going to have cardiac problems, they're going to have arthralgias, and they're going to have neurological symptoms. So if the patient has cardiac, arthralgias, or neurological symptoms, then you know that it's Whipple's disease, and they give you past positive foamy macrophages, then boom, you're already in. Okay? How are you going to treat this patient? That's the question that they're probably going to ask you, right? They're going to say, we did histology, we saw past positive foamy macrophages, the patient's presenting with these cardiac anomalies, with these random neurological anomalies, right? You're thinking to yourself, and they also have arthralgias, and you're thinking to yourself, what the hell's going on? Well, they're going to ask you, how do you treat this patient? And they're just going to give you like a bunch of random stuff. One of them is going to be antibiotics. The answer is antibiotics because it's a bacteria, okay? So overall, once again, this is our malabsorptive syndromes. Take into account celiac disease as the highest yield thing, okay? You have to know celiac disease. But the rest of them are also very important, okay? Pancreatic insufficiency as well. Remember that it could lead to fat-soluble vitamins deficiency, right? Because it can lead to statorrhea. A lot of them do. So whenever you have statorrhea, think that you have fat-soluble vitamins deficiency, and then think back, vitamins A, D, E, K. Well, let's think vitamin D deficiency, then that leads to increased risk of osteoporosis. So that's literally how they're going to talk you through it. And you're going to have to think back to like this tertiary step. Well, a patient that presents with pancreatic insufficiency, they can't absorb fats, meaning they can't absorb fat-soluble vitamins, meaning that one of them is vitamin D. And so without vitamin D, we can have an increased risk of osteoporosis, okay? So like that's kind of the thinking you have to go through for these malabsorptive disorders, all right? Any questions, please be sure to reach out to me.